All right, we are going to talk about nursing care of a child with the alteration in perfusion or cardiovascular disorder, otherwise known as the Cardiovascular podcast. Now, I know you guys have been waiting on this, and I apologize for the delay. I was trying to think about the best way to present this information. There is a lot of information in this chapter, so the way it's going to look, I'm going to split this into two podcasts. I'm going to talk about congenital heart disease in general, some acquired cardiovascular disorders, some congenital cardiovascular disorders, and then I'm going to split the individual cardiac defects up in a different podcast. So this will be almost all of the chapter, and then the next one will be each one of the individual defects talked about, and I'll let you know exactly what you need to know about those. All right, so we're going to go through the chapter here. Now, the PowerPoint for cardiovascular is pretty self-explanatory, so I'm not going to use the PowerPoint. Just know that we're not going to talk about heart transplantation. We're not going to talk about acute rheumatic fever. Well, we are going to talk about one thing about acute rheumatic fever, just that it's caused by strep. But there are some parts that we're not going to touch on just because there's so much information in this chapter. So those PowerPoint slides you can disregard. Everything else are pretty self-explanatory. You'll have to excuse me, my allergies are kicking tonight. All right, let's start with some variations in pediatric anatomy and physiology. Now, real important for you to know how the blood flows through the heart and what kind of changes take place right after birth. So, several changes take place right as that newborn first starts to take a breath. And I've highlighted the areas. You can come back or you can highlight as you go along and listen to the podcast. These are some really important things that you need to know about, okay? So when the newborn first takes his breath, the lungs inflate, and that lets down the pressure in the pulmonary artery, okay? So that also decreases the right atrium pressure. Blood flow increases to the left side of the heart. Pressure comes up in the left atrium. This causes, okay, so the foramen ovale is between the two atrium. So that increase in pressure causes that to close. The drop in the pulmonary artery starts the process of the closure of the ductus. And that's between the aorta and the pulmonary artery. Now, if you look down here, here's a nice picture of all of those parts. So between the atrium, the foramen ovale closes when the pressure increases in those two locations. And then between the pulmonary artery and the aorta is the ductus. And that starts to close at that point. All right, so important that you know what changes take place with that first breath, okay? And that will help you understand the defects a little bit better. Okay, so here there's some structural and locational differences in the infant's and the child's cardiac structure and the adult. It starts out that the heart kind of lays down on its side, and then as the child grows, it kind of rotates into where it's in the position during between 6 and 12 years of age. It kind of rotates to where it's in a normal position, like an adult position. So just know it starts out laying down and then ends up in an upright-ish position. All right, normal heart sounds and normal vital signs. There's some information that you need to know highlighted down there. The different colors mean nothing. I just was bored with yellow. So all highlights are the same. Here's some heart rates. Here's some blood pressures. Know those values. Again, if a value is going to be on the test, it's going to be obviously above the range, because I know that there are many different ranges. There's a different range in your clinical notebook. There's probably a different range on the badge that you use at your pediatric facility. So know that if you're asked a question about a high heart rate or a low blood pressure, it's going to be pretty obvious. All right, some common medical treatments that you're going to see in the cardiac patient. You may see digoxin given for congenital heart defect or heart failure. Going back, I think I said this in the respiratory lecture. CHF, heart failure, congestive heart failure, is pretty much the same in adults and kids. Treatment is pretty much the same. There's some different parameters because heart rates differ, etc. But the basic concept is the same. So this should be easier to understand because I know you guys have just touched on this in critical care. So hopefully that will help. But DIG is one thing that we do treat CHF with in kids. So you need to know some information about DIG toxicity. I think you learned that in med-surg as well. So go back and review your information on that. Oxygen, of course, you'll see these kids are most of the diagnostic criteria or the diagnosis is because they have low oxygen saturation. So they're going to get oxygen most likely. Now there are certain defects that you don't want to give oxygen with, and we'll talk about those when we talk about the individual defects. But for hypoxia, you're going to give some oxygen. CPT we talked about in the respiratory module. That's to clear drainage. If you have a lot of fluid or mucus, that's going to increase oxygenation. You don't really see that a lot in the cardiac patient. I was kind of shocked to see it in this chapter. It's more used with respiratory patients. Chest tube after open heart surgeries, which a lot of the defects are corrected only by surgery, you might see a chest tube. And then pacing, if you have an arrhythmia, if you have AV node malfunction, you might see a child with a pacer, either temporary or a permanent pacer put in. All right, so here's some medications. We're going to come back to assessment because assessment is really important with these kids, with any cardiac kids that you know of, that you know that it's a cardiac problem or that you suspect it's a cardiac problem. We're going to talk about meds real quick. Again, I've highlighted some information that you need to know about each one of the medications. Okay, prostaglandins. All right, so there are some defects where they're called ductal dependent congenital heart defects. That means that ductus, which when an infant takes its first breath, it's going to start to close. It needs to stay open. So in order to oxygenate just a little bit, just because of the defect. So in order to keep it open, they're going to give some prostaglandin. Okay, so it is a temporary maintenance of that ductus arteriosus when we need it to stay open. Okay, so remember that. DIG, and you know what DIG is. It increases the contractility, decreases the rate. You're probably pretty familiar with that. Here are some indications when you're administering digoxin to a child. You need to make sure you count your apical pulse 1 full minute. If the heart rate's less than 60 in an adolescent or 90 in an infant, you hold the med. Okay, remember that, less than 90. And then I'll let you read through the other indications. Make sure that you know signs of DIG toxicity: nausea, vomiting, diarrhea, bradycardia. Okay, important to know those. Lasix. Lasix and DIG are usually the two drugs of choice with CHF with congenital heart defects. Lasix is potassium wasting, so know that you need to keep track of your potassium. Used to manage edema with heart failure. So remember that part. Come on, here we go. All right, indomethacin. Okay, so if you can remember, prostaglandin and indomethacin are opposites. So if you need to close that patent ductus, you give them prostaglandin. Now, back in 1972, they closed patent ductus arteriosus with surgery. I had a PDA when I was 5. Well, it was discovered when I was 5, and they closed it with surgery. Nowadays, they close it with indomethacin. So just remember, indomethacin, prostaglandin, opposites. Prostaglandin keeps it open, indomethacin shuts it. All right, aldactone or spironolactone. It is also used for edema. It is a potassium-sparing diuretic. Now, antibiotics. Antibiotics are given to prevent endocarditis in kids with valvular issues or congenital heart defects that might predispose them to some sort of infection. A lot of times with teeth cleaning, with dental procedures, they're given penicillin, or if they're penicillin allergic, erythromycin to prevent any kind of rheumatic fever or endocarditis. And again, we're not going to touch a lot on a rheumatic fever. You just need to know what it is. It's caused by the strep bacteria. Prevention of rheumatic fever is with penicillin or erythromycin. All right, and unfortunately we do have hypertension in kids. Here's a couple of medications used to treat those. Angiotensin converting enzymes or ACE inhibitors, and beta blockers. Know the signs and symptoms and nursing implications. I think that's what they call it. Yes, nursing implications of each one of those medications as well. Okay, so assessment of these kids. First thing you want to do is ask the right questions. Okay, ask parents, and again, this is newly diagnosed or suspicion of some sort of heart defect. Ask them about shortness of breath, if they get tired, squatting. Squatting is very specific to tetralogy of Fallot. So if they say, you know, my kid just kind of runs and then all of a sudden he'll squat down, that is very, very diagnostic, and that needs to be investigated. Poor feeding, if they fall asleep when they feed. Failure to thrive. Plotting on the growth chart is absolutely imperative that you do that or do this for these kids. If you have a child that is growing in length but not gaining weight, that is a red flag for cardiac issues. So make sure that you're plotting your growth charts. Diaphoresis, if they sweat, if they get so tired they fall asleep when they're eating, then those can also all be red flags. And of course, any kind of cyanosis, tachypnea. We had a little one come in one time that was breathing about 85 times a minute, and he ended up having an AV canal defect. So that respiratory rate, very important that you get a good one. All right, so here's some more information or some more examples of questions that you might use to ask about a child's health history. Past medical history. All right, especially birth history too. Family history of any of the diabetes, obesity, early cardiac death. Those are all questions to ask about family history. All right, physical exam. Make sure that you get their height and weight. Cardiac patients will be a daily weight too if they're diagnosed as a cardiac patient and they're inpatient. Make sure you have, if the patient has heart failure, goes home, make sure you have mom and dad keep a close eye on their weight as well. All right, you're going to look at their skin. Of course, noting any cyanosis. You're going to look for edema. In babies, you can get facial edema, like periorbital edema, and then you can get presacral edema, because it's a dependent area of the body. So look at the face and look at the back, and then check out the extremities. All right, so if you've got a child that's cyanotic or that's hypoxic and you put oxygen on them and they don't raise that oxygen level, then that could be a red flag also of some sort of congenital heart defect. You're going to look at fingers and toes for clubbing. Of course, this is chronic hypoxia, so you may not see that initially. All right, and then just know that if you have a child with a cardiac defect, they may chronically be low oxygenation. They may always be 85 or 90%. You need to, when you do your assessment on those patients, you need to ask the parents, what is his normal O2 set? And then if they say, oh, it's 85%, then that's what it is. I would not apply oxygen at that point. All right, real important, actually, the cardiac cycle right here, I would urge you to watch that. It's about 2 minutes long, I think, and it shows the circulation through the heart. Real important to know that. All right, so more physical assessment. Accurate heart rate. You listen for a minute, you listen for an apical pulse. Bounding heart rate or bounding pulse is characteristic of a PDA. Make sure you feel their belly. Right-sided heart failure can result in hepatomegaly. All right, check their pulses. You need to document if their pulses are equal, if they're bounding, if they're thready, etc. All right, so you're going to listen to the heart. You're going to listen apical to an apical pulse for a full minute. All right, now some kiddos, especially like teenage boys, have a little bit of an irregular heart rate anyway. So you're going to note that if they're regular, if they're tachycardic, if they're bradycardic, if they have a murmur, again, you don't need to stage, or yeah, you don't need to give me a grade on the murmur, or you don't need to be able to identify that, you know, at this point in your career. If you are a cardiac nurse, then yes, I would expect you to know how to do that. But here is a breakdown of the grades. S1, S2 are normal heart sounds, of course. S3 may mean something's up, but a S4 pretty much always means that there's something not quite right. You can hear some splitting of S1 or S2. So just know your normal heart sounds, and if you hear an abnormal heart sound, get somebody else to investigate that with you. Blood pressure. Blood pressure in upper extremities and lower extremities, especially if you are a known cardiac patient, you want to get blood pressure at least upper and one lower. Let me see if there's anything else on blood pressure. If you do determine that there is a difference between upper and lower, that is a abnormal finding, and you need to let somebody know about that. And any hypotension and hypertension. All right, some lab and diagnostic testing that you might see used with these kids. Arteriogram looks at structure. If they see something that they might suspect as being a cardiac defect, maybe on an x-ray, then they may go deeper and look for structural defects in arteriogram. Holter monitor. If you have a child that you suspect of SVT or some sort of arrhythmia, then you might see a 24-hour Holter monitor. And again, this has nursing implications. I love these charts. So nursing implications to go with each one. Chest x-ray is going to show you size of the heart. It's going to show you location of the heart, because there is a condition I don't think they talk about in the text called dextrocardia, where the heart's actually on the right side of the body. An echocardiogram. So an echocardiogram is going to tell you, it's going to help you with cardiac output. It's going to help you with valvular issues, valvular defects, and again with some structure. An EKG, if a child comes in, or ECG, sorry. If a child comes in with chest pain, of course you want to get an EKG. It's going to show you conduction issues, rate rhythm, etc. Exercise stress test, you don't really see that a lot in kids, but it can be used. H&H. Okay, so an H&H can determine polycythemia, which is a effect of congenital heart disease. So we'll talk about that when we talk about congenital heart disease as well. And then partial pressure of oxygen, partial pressure of oxygen, it determines the real degree of hypoxia. It's more definitive than a pulse oximeter. All right, so cardiac cath. A cardiac cath, you'll see a lot of these done to diagnose congenital heart issues in kids. Pretty much any child that we suspect that has a cardiac defect will get a cardiac cath. There's 3 different kinds. You can have a diagnostic, an interventional, where they go in and try to close something or open something, or a electrophysiologic, and that's to measure the conduction. Most of the time they're diagnostic or interventional. They can close VSDs with a cardiac cath. Lots of new procedures happening every day in the pediatric cardiac cath world. There is a lot of information here on cardiac cath. What I need you to know is the nursing management. Okay, what do we teach our parents before the procedure? What do we teach them will happen after the procedure? The risk of the procedure. Okay, you want to monitor them for afterwards for bleeding, any arrhythmia, hematoma at the insertion site, and infection. Okay, here's the indication, and just because I don't have it highlighted doesn't mean that it's not important. Okay, especially this part after the procedure. Okay, you're going to have to evaluate their neurovascular status to make sure that we don't have a clot formation, occluding the blood flow in the legs, bleeding, etc. Very important box here. So I would read through that. Here is some aftercare for cardiac cath, and this is going home instructions. Okay, let you read through that. All right, so once you assess these kiddos, then here's some nursing diagnosis that you might choose from. Decreased cardiac output, ineffective tissue perfusion, of course, risk for infection, excess fluid volume, those are the activity intolerance, those are the biggies. All right, congenital heart disease. Very high prevalence in all right, so we're going to skip the congenital heart defects, and we're going to do those in a separate PowerPoint. We're going to move down to acquired cardiovascular disorders. Acquired cardiovascular disorders, rheumatic fever, we're just going to touch on quickly. Cardiomyopathy, we're not going to talk about. Infective endocarditis, we're going to talk about just briefly. Hyperlipidemia, hypertension, and Kawasaki's disease we'll address. Heart failure can occur as a result of congenital heart defects. Now again, I said heart failure in kids is very similar to heart failure in adults. Okay, so I'm going to let you read through the pathophysiology. Okay, here's how we treat it. We treat it with DIG, we treat it with diuretics like Lasix, and that's pretty common in adults as well. So this should be pretty, well, it should be a little easier to understand now that you've had that in your critical care course as well. All right, when you're getting a health history on these kids, real important to talk about feeding, weight gain, those types of issues. Look at their growth chart. Again, a linear growth without weight gain should be a red flag that something's not quite right. If they get short of breath, if they sweat whenever they eat, if they're irritable, those are all signs that you need to investigate the cardiac issues. When you're weighing the kiddo, if they've gained a lot of weight in a short period of time, could be edema from not eliminating fluid off their body. So listen for a murmur, look at their belly, all good physical exam tips right here. Might want to get a chest x-ray that again shows you the size of the heart, any kind of pulmonary edema, location of the heart, position of the heart. So what are we going to do for these kids? Well, we're going to make sure they stay oxygenated. Okay, so we're going to have to do some parent teaching as far as how to best promote oxygenation in the kiddo. Upright position, make sure to keep those airways open, lots of suctioning, etc. Supporting the cardiac function, we may be giving DIG, okay? We may be giving DIG in the hospital and then sending them home on digoxin. Lots of teaching interventions needed when you are, telling parents to look for the signs and symptoms of DIG toxicity. Make sure in the hospital that you get a heart rate and a blood pressure before you give any kind of digoxin or Lasix. Lasix drops blood pressure, so make sure that you can maintain that. Potassium as well. All right, providing adequate nutrition. These guys are going to get tired when they feed, so they may need more frequent feedings. And concentrated calorie infant formula. You can go up to 28. I think there's actually a 30 calorie per ounce formula now. So if they're a failure to thrive, you need to address that as well. All right, so congestive heart failure or heart failure can result from congenital heart defects. Again, we'll talk about those. Infective endocarditis is a bacterial, it can be a fungus, but most of the time it's bacterial in nature. It involves mostly the valves. You hear about valves being infected with infective endocarditis. What you're going to see when you assess these kids, it's very vague. Okay, so they have body aches, they have chills, fever, weight loss, very just kind of flu-like symptoms. So it's kind of hard to pinpoint unless they have some of the very specific signs listed here. Now, I personally have never seen any of those signs, nor have I seen a child with infective endocarditis. So those are all specific signs that might occur with that. All right, so nursing management. If you've got a suspected or if you've got a potential for infective endocarditis, you should, and this is the listing of the ones that you should be giving prophylactic antibiotics for. If they have a prosthetic valve, if they've had endocarditis previously, if they have a congenital heart defect, those are all signs, or all indications that you need antibiotic therapy before you have any kind of dental procedure or invasive procedure. All right, an acute rheumatic fever, remember I said we're not going to touch on this. Just know that strep, if you have signs and symptoms of like the flu type illnesses, body aches, chills, joint pain, after a strep infection, then they may think acute rheumatic fever. So we're going to skip through that. We're going to skip through cardiomyopathy. We are going to talk about hypertension. Unfortunately, hypertension is becoming more and more prevalent in especially our teenagers. Some kiddos with renal disease, hypertension is the first clue that we have that they have something going on, renal disease. So is a blood pressure important in a child? Absolutely. Is it easy to get? Absolutely not. Especially in an infant or a toddler. So if you don't get a good blood pressure, you need to get a good blood pressure. So try and try and try again. It's probably the hardest vital sign to take, but really, really important. Again, in kids, blood pressure, high blood pressure is basically the same pathophysiology. Here's the health history that you're going to get. Family history of high blood pressure, family history of hyperlipidemia. If the child is obese, if there has been any renal issues going on, including frequent urinary tract infection, because remember, you can get glomerulonephritis, which can cause high blood pressure as well. Here's the signs and some other signs and symptoms that you need to look at. If they've had nosebleeds, if they've had blurred vision, any of those signs and symptoms of adult high blood pressure, headache, etc. You want to look at the skin. Neurofibromatosis, you can see cafe au lait spots, which causes, neurofibromatosis may cause high blood pressure. The cafe au lait spots are associated with neurofibromatosis. And cafe au lait spots are large, kind of hyperpigmented brown areas on the skin. There's a certain number of cafe au lait spots that you have to have in order to suspect neurofibromatosis, and I don't know off the top of my head what that is. So how do we manage high blood pressure? Same way you manage it in adults. Usually there's medication involved, a low sodium diet. Sometimes they restrict fluids. If the child is obese, then they work on weight control, exercise, increasing activity, etc. All right, Kawasaki disease. Let's talk a bit about that. It is a vasculitis. Usually doesn't occur after age 5, but I've seen a 7-year-old with Kawasaki before. The leading cause of acquired heart disease among children. Remember that part, okay? They really don't know what causes it. They think it's some sort of infectious organism. They treat it with IVIG and high-dose aspirin because one of the outcomes can be coronary artery aneurysms. So that is, and cardiomyopathy. So that's what they try to prevent. On down here, you're going to see what you see with Kawasaki disease. You're going to see fever, extreme irritability. These kids their eyes are bloodshot, their skin's peeling off their fingers and toes. They get a strawberry tongue. It's real cracked. Their lips are all chapped. They're miserable. So irritable kids with fever. You look at that tongue. If it's a strawberry tongue, and that's exactly what it looks like, is like a strawberry, then you might think about Kawasaki. And then just know that the outcome from Kawasaki can be coronary artery aneurysms or cardiomyopathy. That's why they treat with aspirin and IVIG. All right, their eyes are going to be just so bloodshot. That is kind of like a hallmark. All right, so what do we do to help these kiddos? Well, other than giving IVIG and aspirin, you're going to just try to make them comfortable. Put stuff on their lips to make them more comfortable. Pain control, treat the fever. Keep the lights turned down. Those are all important. Teaching, there's some information about providing child and family education as well. All right, hyperlipidemia. Unfortunately, hyperlipidemia, again, is becoming more and more prevalent in the adolescent age group. It can also be familial. Some kiddos have hyperlipidemia noted early in their childhood. We start testing, I think, about age 9 or 10. We screen for high lipids, especially if there's a family history. Okay, these are the things that you're going to assess the family history for: sudden cardiac death, coronary atherosclerosis, high blood cholesterol noted. And these guys don't have to be, they don't have to be overweight. They can be stick thin and still have high cholesterol. Again, assessment starts about age 9 or 10. We start checking blood work at that point, and if diagnosed, Sometimes they are put on medication. They're definitely put on dietary restrictions, etc. All right, heart transplantation we're not going to talk about. And here is your care plan. Okay, so I would read through this care plan very closely. It's very generic, and it talks about increasing cardiac output, encouraging fluid loss, promoting nutrition, promoting tissue perfusion, of course, addressing the growth and development, preventing infection, and family coping. Also talks about activity intolerance, because that can be a huge issue with these kids. They get tired very, very quickly. All right, so that's part one of the cardiovascular system.